All right, I guess we can open up the room. It's top of the hour. Hello, everybody. Happy Monday. Happy Monday to everybody. It is early for those of you on the Pacific Coast, Pacific time zone. For us East Coasters, it is lunchtime, so maybe you're having our lunch with us, but we want to welcome you to our program today. My name is Anissa Mitchell, and I'm with PMD Alliance, and I'm very happy to see all of your faces on a Monday. Great way to kick off the week. So I want to just do a bit of housekeeping before we launch into our discussion today. First of all, we are going to invite you to interact with our speakers by unmuting yourself. Until we actually get started, we'll keep everybody muted just to reduce any background noise that can occur. If you see at the bottom of your screen that we do have live transcription or closed captioning, potentially showing up. If you want to keep that, you can actually hover over it and move it around on your screen, or you can click that live transcription button where it pops up a little box that says hide subtitles if that's distracting to you. We also invite you to open up your chat box. Give us a shout out from where you're joining us from. We'd love to see where everybody is coming to the program from, and feel free to chat your questions. So we're going to give you the option to either raise your hand and say, hey, I want to ask a question in person, or you can chat your question. So if you want to raise your hand, because we can't see everybody at the same time, just the way that the gallery view is. There are little reactions at the bottom. You can click that and it'll give you the option of, like, clapping, thumbs up, raise your hand. That way we can see that you are interested in asking a question in person. So feel free to do that. So I want to get started. So we are having a discussion today about sexuality and intimacy in Parkinson's, which I love having this discussion about. I feel like it's one of those topics that I was just telling our two speakers, Dr. Ospina and Erica, that it's kind of like that elephant in the room. It's something that we should be talking about, that we probably want to talk about at times, but may not know how or feel a little uncomfortable. So we're going to be talking about some things today that might have been on your questions list. I want to share with you who our speakers are. Most of you know Dr. Maria Cristina Ospina. She actually was with us last week in a live stream, so it's great to see her again. For those of you who are not familiar with her, she is a movement disorder neurologist. She is in private practice, as well as also an assistant professor of clinical neurology at the University of Arizona. Dr. Ospina is very active with PMD Alliance. She's very active in medical research. She participates in numerous studies, including those of the NIH, and is part of the Parkinson's Study Group. So we're glad to have Dr. Ospina with us. And we also have with us Erica Vitek, and she is an occupational therapist. She is with LSVT Global and is LSVT Big certified, but she's also a practitioner with Aurora Healthcare Therapy Team at Aurora Sinai Medical Center in Wisconsin. And she is board certified in biofeedback for pelvic muscle dysfunction and pelvic rehabilitation practitioner. So she's going to be talking to us from an occupational therapy and pelvic floor perspective, and how that plays a role in our sexual health, both for men and women. So ladies, thank you so much for joining us.
Thanks for having us.
Yes,
Awesome.
thank you for having us.
Well, let's launch into this. First of all, I want to debunk a couple of myths about sexuality as we age, because a lot of things that I've heard is that older people don't want or need sex anymore. It's wanting it when you're older is considered inappropriate, or you might be too fragile or weak to have intercourse or any form of sexual pleasure, and that there's a lot of things that you just can't address physically or medically that can impact our sexual life. So I'd love for us to launch into debunking some of these things and maybe talking about a prevalence of sexual dysfunction in Parkinson's.
When you start off. So, I mean, sexual dysfunction is part of those non-motor symptoms of PD. So that autonomic dysfunction, just like you have trouble with the bladder, urgency and frequency, trouble with the blood pressure where it drops too much or you're orthostatic, then you can have trouble with the sort of the parasympathetic part of the sexual. So, it's point and shoot, that's you can't get an erection. And so you can have erectile dysfunction as part of the non-motor symptoms of Parkinson's disease. And also you can have some apathy, anxiety, or depression, and that can also lead to a decreased libido in Parkinson's disease as part of the non-motor symptoms. And then there can be the social aspect of it. So you might have a tremor, you might be dyskinetic or have the involuntary movements, you might have trouble with drooling, and you might not feel very sexy and feel like, well, I don't know if I want to be in lingerie or be next to my partner. So there's many reasons that are reasons why sex is affected in Parkinson's disease. And then the other thing that happens is, remember that you're on all of these psychoactive medicines for Parkinson's disease. And part of the side effects of your dopamine agonists, those are medicines like Mirapex or pramipexole, ropinirole or Requip or Nupro or the rotigotine patch, is hypersexuality. Is one of the side effects of those medications. So not only does the plumbing not work very well, but now we've added medicines that sort of increase the libido, and now we've caused a problem where you have the urge, but then you're like, oh, what do I do? So there's lots of things that, and remember, we always want communications, not only between you and your doctor, but you and your partner, to try to solve these things and get to a point where you're both happy. So there's many reasons. So if people want to ask specific questions, and then the other thing, another thing that happens is, remember that anxiety and depression are part of the non-motor symptoms of Parkinson's disease. And we treat that with SSRIs, medicines like Prozac, Celexa, Lexapro, but those can cause anorgasmia. So you might, be on Mirapex, which increases your libido, but we've added some Prozac or Lexapro because of the anxiety and depression. Now you can't reach orgasm. So, but if you don't tell your doctor about that, then we can't fix that. Then we can't switch you over to Wellbutrin or another antidepressant where we don't have that problem. So I think still communication is the key to everything, not only with your doctor, but with your partner.
And Anissa, I can just add on prevalence information as far as from a pelvic health standpoint. So there was a study, questionnaire-based study that they did in 2001. And there is not an abundance of literature on pelvic floor and Parkinson's disease, but there was this one study done, questionnaire-based, and they looked at 115 people with Parkinson's in comparison to 391 in a control group, a questionnaire about bladder and bowel and sexual health function. And they did find within that study that decrease in libido, as Dr. Ospina said, and decrease just in generally having sexual intercourse or decrease in orgasm ability was fairly prevalent in people with Parkinson's in compared to the control group. And then also dissatisfaction in the quality of their sex life was also higher. And in this particular study, women were less dissatisfied with their sexual health, and it was more prominent that men reported dissatisfaction in sexual health. But also in the general population, as we age, there tends to be some dissatisfaction, and other health conditions can get in the way sometimes, but that doesn't mean there aren't things that we can do about it.
Right. And I think, because Parkinson's disease tends to affect sort of the Medicare age group, people above the age of 63, that's postmenopausal patients. So, you've got all those postmenopausal changes. You can have erectile dysfunction for many other reasons other than Parkinson's disease. But I think we need to get away from this idea. I mean, a part of the dissatisfaction comes because you think, well, sex is only intercourse. It only involves penetration, and we have to think widely and a little bit outside of the box that what else can encompass sex and a happy sex life with my partner.
And can we talk a little bit about that differences for men and women in relationship to some of the actual dysfunction? So we know with men, they have erectile dysfunction. For women, it is typically lubrication issues. Are there other issues? And when we talk about sexual satisfaction, is it because of either no orgasm or dulled orgasm?
Okay, I can start with that one, Dr. Ospina. So as far as for women, a lot of women may experience the anorgasmia, or they also may experience pain. So with penetration and or just that lack of lubrication that is lost because of reductions in estrogen production as we get older, or if you've had a female surgery, such as a surgery on the uterus, a hysterectomy, or removal of the ovaries or something like that, that affects the estrogen production. And then what happens is you get thinning of the vaginal canal. And then because of that, then friction becomes more challenging. And so there are a lot of different products out there that can help with that. And in therapy, I have some suggestions that I usually give: water-based lubricants, silicone-based lubricants. So when you think about different kinds of lubrication, those things can really help a lot. Water-based lubricants tend to wear off a little faster, but sometimes are more tolerant for people that have maybe sensitive skin. Silicone-based lubricants are slipperier, so they do help with friction for penetrative intercourse. So that can be something that can be used. And also, if there is pain in the pelvic muscle, we can work on that in therapy and work on stretching and different techniques with muscle exercise to relax the muscle to allow for more penetrative intercourse. And then for men, a lot of times it is the erection issue. And so I usually, as far as from a therapy standpoint, ask, there's 3 different types of erections that I usually would ask about. So there's a psychogenic erection, where if you are watching something that is pleasurable or interesting to you as far as sexuality, can you get an erection that way? Can you get an erection in the morning? Like they're called nocturnal erections. So does that still happen to you as you're getting older? And then also a reflexive erection would be one where if your partner or yourself, if you self-stimulate or your partner stimulates you, can you get an erection that way? So I would first like to kind of dig into that, and I'm sure a physician would do that as well, to kind of figure out what's going on with that person's nervous system, and to see if there's any ways we can kind of dig into that as far as therapy goes, and recommendations maybe to enhance the area of the erections that might work better for that particular person, and kind of build on that for them.
And I think there's the myth out there that for men that you have to have a full erection to reach orgasm. And so that's not actually true. So even if you can't reach a full erection, you can still have an orgasm. You can use oral sex. So that's shouldn't always be if I can't reach a full orgasm, then that's it, my sex life is over with. That's not true. And then there's many medical, pharmaceutical medicines that we can use to try to reach a full erection. And again, as Erica was saying, lubricants, water or silicone, water's usually generally safer for patients who are still using contraceptives and patients using sex toys. And as Erica said, silicone lasts a little bit longer. It's a little bit more slippery. You can use estrogen creams. There's sort of like an E-ring that you can sort of put up in the vagina that it helps keep it lubricated, and so that intercourse is not as painful. But if you don't discuss these things with your doctor, then they're not going to be able to offer them to you. So again, I think always the key is communication, and to communicate these things with your physician and your partner.
And for those who do experience erectile dysfunction, there's medications, but there's also other forms of assistance, such as like rings and things like that. Can you touch on that a little bit?
Yeah, so it's just not, medicines like Viagra or Cialis or that sort of thing. There's also Uhimbing, like an injection, although that's not very popular, that you can use. And then you can also use a ring, something that keeps the penis erect, and so that you don't lose the orgasm so quickly. So there's many therapies out there. You just need to explore them and see what works the best for you. And again, always ask, because if you don't ask, people can't give you what the options are. And remember, you don't always need a full erection to reach orgasm. That's a myth that's still out there, especially, if you're 70 years old or 80 years old with Parkinson's disease. You can still have a full sex life. We just have to think outside the box.
One person said, so we should talk about age appropriate sex. That's a question. I'm not sure. I think that kind of goes back to the myth of that there is an age appropriateness to sexuality.
Right. So, I mean, you know, many times you may be worried about a tremor or dyskinesia, or, you know, you're worried that am I going to be using sort of a sex swing or something like that. You know, maybe that would be sort of age appropriate. You don't want to fall off or anything like that. But I think that you can, you know, as long as you're communicating with your partner, you can have a very satisfying sex life. It wasn't probably what you had in your 20s, but now you know your partner better. You've, you know, known them for many years, sometimes decades, and that counts for a lot. But I think, you know, in Parkinson's disease, you know, many patients will say, well, I still have the urge, but, you know, my spouse is turned off by the dyskinesia or by the tremor or by my drooling. And so we want to address that. So if you're having a lot of trouble with drooling, you know, we can treat that. We can treat that with Botox or Xeomin to try to shut down the submandibular gland so that you don't have as much drooling. We can use sugarless gum or suck on a hard candy, so that, and then you can address that and you can talk about it with your partner and say, well, you know, I understand that's sort of off-putting, but let's try to do this or XYZ about it. Or with my tremor, let's time my medications better so that I don't have so much tremor or I don't have so much dyskinesia. But again, the key is open communication with your partner so that you can address these issues instead of just saying, well, probably, you know, they're not attracted to me anymore if I, you know, have this Parkinson's body, or if it's always dyskinetic, or if I'm drooling, maybe my spouse doesn't think I'm sexy anymore.
You brought up a couple of points that I want to go back to. So one was medication timing. So trying to, instead of feeling like sex always has to be a spontaneous act, that actually planning it around your best time of day and when your medications are on could make it a lot better for a couple. And maybe even give somebody something to look forward to. Can you talk a little bit about that whole, you know, medication timing and off, and maybe how if someone is on and they do have some dyskinesia, like how that medication balance and all that can impact. And then I want to go into some other ways of addressing this from an OT's perspective.
Yeah, so just like you would plan your golf game during your best on time, you know, you could plan your sex life around that as well. And so, you know, we time our medicines and we treat, you know, every time you have an off period, you want to take the medicines right when you're having the off, not when it's, you know, when the clock says if you're on 8, 12, 4, and 8, and if you wore off at 11 because you were doing physical therapy or something else, then we want to time your medicine to when your body wore off, not when you were supposed to take the next dose, because it's the clock doesn't have Parkinson's disease, your body has Parkinson's disease. And if you wait too long to take that next dose of medicine, remember it's a pill, it gets hung up in the stomach and it takes too long for it to migrate into the small intestine, and then you spend more time off. So once we learn what on and off is, and on is when you feel normal, you feel like I don't have Parkinson's symptoms anymore, my tremor is better, my rigidity is better, and off is a return of your Parkinson's symptoms. And then now we're super lucky that we have once a day versions of a lot of the medicines, your MAOB inhibitors, COMT inhibitors, dopamine agonist. We have longer acting forms of levodopa, so we would always want to be picking a longer acting form of levodopa like Rytari if the insurance allows it, so we're not peaking and troughing so many times during the day. And then we've got 3 different kinds of rescue medicines, all of which bypass the gut, so that if you do happen to wear off or forgot a dose or were late with a dose, then you could take one of the rescue medicines, like we talked about last week, like Kenmobi or Ambrosia, that we inhale the levodopa. So instead of going gut to brain, it goes lungs to brain. And so you kick in much faster in 15 to 20 minutes or 30 minutes instead of waiting a whole hour, so that there's many ways to keep yourself with a sort of a steady state of dopamine throughout the day. And so you're not peaking and troughing, on with dyskinesia and then off. So again, planning the way you take your medicines and planning your day. Well, actually, our whole goal with the medicines is so that you don't have to plan your day around the medicines. Is the reason why your doctor is going to be choosing these once a day medicines and the longest acting form of the medicines, and then a rescue medicine is if needed, so that we don't have to plan your day around your medication. But then if we need special activities, then we would want to make sure that we're on during that time.
And Erica, one of the things that I would love to hear your perspective on is helping people with dealing with energy. So if I'm, expending a ton of energy just to get through my normal day-to-day activities, I may not have a lot of energy left for having sex. So how does energy conservation play a role in helping people? And what are some things that you have recommended to some of your patients that may have been trying to kind of figure out how to navigate some of the challenges they're dealing with?
Yeah, so a lot of times the kind of what Dr. Ospina was referring to right in the beginning is you kind of plan your golf game around your on time, and that kind of fits with the energy piece too, that maybe first thing in the morning is actually better. You maybe move a little bit better. Maybe there is definitely more energy in the morning, and that is the way to do it. I mean, I've had people plan a particular day of the week that's the day that they're going to focus on each other and be together on that day in the morning when they're feeling more of their on time. And so just being more comfortable with their own body and how they can move at whatever time of day that is, it can definitely be helpful. And I would agree with you, Anissa, that by the end of the day, a lot of people tell me they're completely exhausted, and that might not be the time to initiate that. So to each person, has kind of their own when they feel good. And so that would definitely be something to consider. And then weekends might be easier. Like if you're still working or a little bit busier during the week, weekends might be a more relaxed time. Dr. Ospina also mentioned a great point in the beginning about our parasympathetic nervous system and how that's kind of our rest and digest system. And it also helps with erection and being more relaxed and being aroused. And so when we can be more relaxed, that actually sometimes can also just play right into that energy level as well. When you have more energy, but you can also just relax the system down a little bit so that you can be aroused, can be really, really helpful.
Oh, you're bringing up so many different questions in my head to kind of spear off of that. So one of the things is sleep disorder. So if you have a loved one who is dealing with REM behavior, sleep disorder, and they're sleeping in separate rooms, that can impact intimacy also. I don't know if you want to touch on that briefly, Dr. Ospina?
Yeah, so I mean, many PD patients, they sleep in separate bedrooms because of RBD or REM sleep behavior disorder. So RBD is when you go to sleep and you go to REM sleep. REM sleep is your dream sleep. Usually you're paralyzed so that you don't act out your dreams. But in Parkinson's disease, that paralysis doesn't take place. And so you're free to act out your dreams. So you can talk, yell, scream, kick and punch. And so many times the bed partner, wakes up with bruises and that sort of thing, or there's lots of screaming and hollering. And so they many times end up in separate bedrooms because of the Parkinson's disease. So again, we want to plan and say, well, it's, not going to be spontaneous in the middle of the night at 2 a.m, so that we're just like we're going to plan it around my best on time. We're going to plan to have, like Erica said, a day together, either on a weekend or on a Wednesday, a day that I don't have rock steady boxing or physical therapy. We're going to use up all of my energy. Remember, the energy in Parkinson's disease, we want to use it like a savings account. We don't want to use up all our savings all in one day. We want to make sure that our savings account lasts for a long, long time. And that's the same thing with our energy in Parkinson's disease. So again, if you're not sleeping in the same bedroom, then, again, communication, so that you have to communicate with your partner and say, hey, I still have these needs. I still want to do this. What do you think about that? Because if you don't pipe up and ask, then nobody knows what you're thinking or feeling.
There's a really great book about a couple. Lucille Carlton is the author, and it's called Sex, Love, and Chronic Illness. And she's the wife of her husband who has Parkinson's disease. And she talks a lot about the bed separation and how he didn't want to have the bed separation. And they kind of just go through their relationship as they tried to struggle with the sex issue. It's a really, really short, easy read, right around 150 to 200 pages. And it's a really great book. So Sex, Love, and Chronic Illness by Lucille Carlton. I usually recommend that one a lot to my patients.
That's actually a great segue into a question that had come in. This person wrote, I'm 83 years old and I have no interest in intimacy. My husband has been impotent since 2003 after a prostatectomy. My hormone level is like a 9-year-old, and while I like cuddling, all efforts to do so go immediately to fondling, which now feels like groping and also reaching for the crotch, which is useless as I also wear incontinence pads. And they wear diapers, so therefore we can't be spontaneous, and dressing again is kind of a turnoff. So resent being told how I should feel sexually, and that's a thing. Nobody should feel that they have to feel any certain way sexually, and nor does sex need to be intercourse. So can we kind of go down that path a little bit, because I think people often think that sex is literally just penetration or oral sex, and that may not be either something that they're physically able to do or they're not comfortable with any longer for a variety of reasons, but doesn't mean that there can't still be physical contact that's intimate. So maybe we can touch on some of those thoughts.
Yeah, I think go ahead, Erica.
Okay, I was just going to mention that like finding a good sex therapist or something can really help with this because it can help work through a couple issues that might come up. And I mean, Anissa, when you were saying that person's story, I thought of many things, but that was one thing that came up. And there is a website where you can find a sex therapist in your area. So the website is I'll just say it out loud, AASECT. So it's the American Association of Sexuality Educators, Counselors, and Therapists. So it's AASECT.org. And when you go on there, you can find someone in your area that actually is associated with them, that has the training to help couples work through some of those things. The sex therapists typically take the route of working through like emotional type intimacy and having that kind of intimacy, different kinds of physical or sensual kind of intimacy versus more of the erotic or penetrative or touching kind of intimacy, more in the sex like category, what you would typically consider. But even like a mental and spiritual kind of intimacy. So those might be some of the areas they might hit on, try to work on the timing as a couple, and the intimate time versus the dating time versus erotic time and things like that. And so it can be really helpful to work with someone on that. As far as the incontinence goes, being a pelvic health therapist, that is something that I would absolutely address with the person. I would work on the incontinence and ideally eliminating the incontinence, hopefully, to work on that. And there are a few ways you can find a therapist that could help you with that. So there's the Biofeedback Association, which is bcia.org. And that is where you can find a pelvic health specialist that specializes in biofeedback, which helps to train the pelvic muscles to help with incontinence. There is also hermanwallace.com. And that is where you can also search for, find a practitioner that specializes in pelvic health. And then there's also the APTA, which is the American Physical Therapy Association, and they have specialists in pelvic health as well, where you can find a practitioner that works in pelvic health. So there's a lot of resources to find someone in your area that could address some of those surrounding things: fecal incontinence, urinary urgency, wearing pads, all those kind of things. And then we also have the education in the sexual health piece, recommending lubricants, recommending different toys, recommending different ways to say, for one example, reducing the depth of penetration. So like I mentioned before, painful intercourse for the female. And there's something called an ONUT, OHNUT, and there's actually onut.com. OHNUT and actually it's .co. It must be different a country, but I have had people purchase similar things like that before. And what that does is reduces the depth that the male partner, if you have a male partner, that they would go into the female to help with pain, and you could still have penetrative intercourse. So those are just some examples from my end of things.
That's fantastic. So we're getting a lot of great questions, and so I want to make sure that we're touching on them. So real quickly, one person wants to know why Viagra takes an hour before it's effective.
So again, remember, Viagra is a pill. You swallow it, and in Parkinson's disease, remember you have bradykinesia, which means slowness of movement. That affects all of the movements of all of the muscles in the PD body, including the muscles of the gut. And your gut is a muscle. So you swallow that pill, it ends up in the stomach, but it actually doesn't get absorbed until it gets into the small intestine. And so in Parkinson's disease, you have constipation. So the reason why you're constipated is more fluid gets sucked out of the stool gets hard and you get constipated. And then that gastrocolic reflex doesn't work, so that when you swallow something, whether it's a meal or a pill, it ends up staying in the stomach longer than it should. And you notice that sometimes if it's levodopa as a delayed on, I took my pill and it took an hour to work because it took that long to migrate from the stomach into the small intestine. So again, it's the reason why all of the rescue medicines in Parkinson's disease bypass the gut, so that we can give you a faster on, whether it's Ambrosia, where we inhale the levodopa and it goes lungs to brain, or Kenobi, where it dissolves in the oral mucosa of the mouth, so it doesn't have to go into the gut, or apomorphine, where we actually inject it. So that's why Viagra, because it's a pill and you have gastroparesis, which means a slowed gut in Parkinson's disease, then you notice that as a delayed on, it took an hour to work. But in those cases, you can use Cialis or something that works for longer period of time, so that you don't have to take it right at that moment. You can take it and then it's still going to work 2 days later.
All right, so I'm going to switch gears just a second, because I've seen a few things coming through to me directly, and this is more from a psychosocial perspective. I want to talk about couple of things. The differences between women and men in sex. So sometimes men like sex to reduce stress, and women like to reduce stress to have sex. A lot of times, I'm not going to overgeneralize, but you've got a lot of the women who are care partners out there, and they're doing a lot. And, there might be physical issues that are, challenging to navigate, that we've kind of touched on, but then there's just that whole stress factor of being a care partner, and the importance of having time for themselves, to what I always call it bridging time, like moving from doing to being, because intimacy should be kind of a mindful, almost like a mindfulness time for the two of you as a couple. So how can we help our care partners with their own stress, and what would you say to them so that they can then be more available or more interested in having those intimate moments, when sometimes they're trying to also navigate role reversal and some of that strain that they experience of almost feeling like like they're caring for somebody as opposed to being the spouse and getting back to that relationship. Can either one of you kind of touch on some of that?
I do recommend a lot of times like meditative kind of practices or guided imagery or things like that, to like take some time for yourself to really focus on yourself. There is a really simple one that I recommend a lot. And this could be for the care partner or for the person with Parkinson's, but specifically in the case that you're talking about, Anissa, for the care partner who just needs to maybe just kind of downregulate the nervous system a little bit and take some time for themselves. And it's called 4-7-8 breathing. And so what you do with that is you can even do just 4 repetitions of this can make a really significant effect, is taking a breath of 4 counts through the nose. So an inhale of 4 counts through the nose, that 7 count of holding the breath gently, and then the breath out through the mouth for 8. So breath in for 4, hold the breath for 7, breath out for 8, doing about 4 cycles just to kind of wind down the nervous system, to then even allow for the body to have some desire potentially to even have those types of relations, because when the nervous system is ramped up, those feelings aren't top of mind. There's also a physical therapist that's a pelvic health clinician that has some great just 10-minute relaxation strategies that you can get for free online. And it's at carolynmcmanus.com. So it's CarolynMcmanus.com, Carolyn McManus. And you go to her guided meditations free downloads section, and she has these 10-minute she's like I mentioned, pelvic health practitioner, and they are just excellent to just be able to have that caregiver like wind down a little and get more into that mode.
So I think the other thing also that happens is that, you know, with the medicines, we crank up those dopamine agonists and we make the PD patient very hypersexual, where we've increased that drive, where that brain just has a drive to have an orgasm. But they may have erectile dysfunction, or their partner is postmenopausal, has a lot of vaginal dryness and thinning. And so, you know, there needs to be more care there. She's like, I just can't be here over and over again. So again, we have to sort of have that open discussion and say, hey, listen, can we turn down that dopamine agonist a little bit, turn down that drive to give me a little bit of space that I can move from the caregiver role to the spouse role. And so that we get to the point where both partners have sort of a positive self-image, and so that one partner doesn't feel like, gosh, I'm getting groped all the time. So we certainly don't want that, or they're always reaching for my crotch kind of thing. And so remember that these Parkinson's medicines are psychoactive, and they have a lot of psychoactive side effects, which you may not think of. This is a side effect of a medication, but you know, we can turn an 80-year-old into a little sex addict, even though the plumbing doesn't work. The brain is just thinking about that drive, and it's dose dependent. And as we reduce the dose of the agonist, that drive goes away, whether it's, you know, excessive hand washing in times of COVID, or gambling, or shopping, or hypersexuality. You know, one other thing that we want to also be mindful of is, especially in young onset Parkinson's disease, that, you know, sometimes we're keeping these patients up all night. They're watching pornography, they can't stop that drive. And so we want to be careful about that. That's one of the reasons why they're not sleeping, because they're sort of stuck on the internet. And then, you know, we want to be also mindful of STDs. So we think, oh, you know, I'm 80 years old, I'm not going to get pregnant, I have to worry about those things, I don't have to worry about safe sex or condoms. But, you know, guess what? As Parkinson's doctors, we don't want to be treating drug-resistant chlamydia or herpes or syphilis. And those are all still out there, and still can be a problem if we're not careful.
And I'm glad you brought up the hypersexuality, because that can be a real problem for some relationships, either because the person's persistent in their request, yet they don't always feel relief, or that they enjoyed it, so then they ask again. It could be they've become obsessed with pornography, and that was not something that they had ever engaged in before, which can be a problem, especially if they're in a relationship where that was never something they did before together, and maybe for religious beliefs is you know, difficult for them to accept, and then that causes additional strain. So it's important for people, if they're starting to notice these things, to discuss with the physician that these things are happening, because they can have an impact. And is it true, Dr. Ospina, that it's not just maybe, you know, repeated requests and attempts to have sex or pornography, but there can even be like some bizarre things that they engage in with fetishes and things like that, that they should at least be aware of?
Yeah, so it include fetishes. I mean, so we see a lot of pornography, but you can have fetishes that, you know, a couple was married for 40 years and they never had this. But remember that these dopamine agonists, we increase the drive. And if the drive in your case happens to be hypersexuality, then that's the drive that's increased. And so it's sort of think of it's like, you know, I'm a squirrel during winter trying to get as many nuts as I can. All I think about is where I'm going to get these nuts and collect the nuts. And I can't think of anything else. So it's sort of like being OCD, just like we can make somebody very OCD to where they're always cleaning. And that as we reduce the dose of the medication, that drive goes away and it's easier for them to switch sets and say, okay, I can stop now. I don't have to keep cleaning. I can go on to do another activity. So the same thing, if we make you hypersexual, but now you're on an SSRI and you have anorgasmia, and so now you just can't reach orgasm because you're on an SSRI and your partner has vaginal dryness and doesn't have a lubricant, you know, that's going to be a disaster. So that we need to know that, one, that we've made you hypersexual so we can turn down the dose of your dopamine agonist, that you have anorgasmia. So if you're on an SSRI, we can switch you to Wellbutrin or something else, so that we can fix each individual portion of this problem. And so we don't want it to get to the point where it's been going on so long that eventually you just end up crying in the doctor's office and be like, oh yeah, before I leave, you know, we've been talking about for 30 minutes about falls and low blood pressure, but actually what's really ruining my life is, you know, this high dose of Requip you've put him on. And it reaches this boiling point at the end of the visit. So we want to pick it up right at the beginning so it doesn't become a problem in the couple's life. And especially if there's fetishes or other. So if you know what to look for, and just like you can see the shopping and all of that, because initially the patient is not aware of the behavior. For them, the brain is just doing the behavior. They don't notice that it's anything outside of their usual thing, that they're buying 5 of everything or 1 of every color. And so it's the spouse that notices while they're spending too much time cleaning or they're buying too many things. If we can pick it up early, then it's much easier to fix that problem. And the same thing, you know, we don't want to fix it until we've gotten into some pornography problem or some fetish problem, or it turns out that you've been going to massage parlors and you never did that in your marriage. So we don't want that to be a reason why, especially in young onset, that these marriages fail because of a side effect of a medication.
And I've had several messages, and these are hard topics from some care partners that are really struggling because it's such a difficult conversation to have when they have a loved one that might not be able to communicate clearly, you know, and understand necessarily why they might be redirecting them away from, you know, their requests. There's certainly with facial masking and communication changes, difficulty sometimes in even communicating, you know, wants and needs. But then you have caregivers who are really feeling frustrated because their loved ones may be demanding of sex, and they're just not feeling comfortable with that for lots of reasons, because they're busy caring all the time, and that stress is just weighing too heavy on them. There may be some of the physical things that you mentioned before that are barriers, you know, having incontinence and drooling, and even changes of the texture and the smell of the skin because of medications can be off-putting at times. And then there's guilt wrapped around the fact that their loved one wants to have intercourse with them or some form of intimacy with them, and they either have no desire, that's not something they want anymore in their life for lots of different reasons, or they just don't have the energy. So, I mean, it's so multifaceted. I don't know that there's any one thing that we can say. Certainly a conversation with the movement disorder specialist and potentially seeing therapists. But I feel like I should say to the care partners that having somebody that you can talk to, like a counselor, to help you work through the emotional aspect of it, because there's not an easy answer to some of these issues. So, you know, but it's a real weight on your shoulders to have that. especially carrying the guilt, because you want that. And you might be willing to look into other forms of intimacy, but that might not be what your loved one wants. And if there's a communication barrier, then it becomes really very challenging. So I don't know if Dr. Ospina or Eric, if you either one have something to add to that, because it's just a very challenging thing for our care partners.
So I think communication is key with your partner and with the doctor, so that, and we need to get away from this idea that sex is just penetration and intercourse, and broaden our idea of what it means to be intimate with your partner. And so that you explore more ways to do that. As Erica was saying, sort of having romantic time, erotic time, intimate time, and again, communication is key. A sex therapist can help with that. But again, we want to, especially with your movement disorders doctor, to discuss those so that we can minimize what's happening from the medication standpoint. So it makes it easier for your loved one. Just like if your loved one is having hallucinations or delusions, if you discuss it with your doctor and we can treat those delusions and those hallucinations, then it's easier to manage them. Because if we don't treat them, then there's nothing rationally that you can say to that patient to say, well, I don't see somebody there. There's not a giraffe in this room. I don't see that cat. That just leads to frustration between you and the Parkinson's patients who's hallucinating. So then we have to treat those hallucinations. So it's easier for the patient to say, oh, okay, yeah, if you don't see them, that means they're not there. They're Mirapex people. The same thing with the sex drive. If we can reduce the drive by reducing the medications or the side effects of the medicines, then it makes it easier to have that conversation and say, well, what are other ways that I can be intimate with my spouse that does not require, minutes and minutes and minutes and hours of sexual intercourse, which is painful for me, or that you can't reach orgasm, so it just takes forever and it doesn't turn into something that's pleasurable for either of us. So again, the key is communication, and then to discuss it with your physician, and then to bring in other people like sex therapists, discuss it with your support group, because I guarantee that other people in that support group are having exactly the same issues that you are. You're not the only one. And the more you talk about it, then you can figure out, just like you guys figure out about freezing of gait. Like, what do you do when you have freezing of gait at 2 o'clock in the morning, going down a long hallway to the bathroom? If you put some tape down and you have something to physically step over, I can make that freezing of gait better. So you can exchange tips amongst yourselves in the support groups as well. But again, communication is key for all of this.
Yeah, I completely agree, Dr. Ospina. And I have a lot of people that will come to me, say, for example, from the urologist or from a gastroenterologist. So they see their GI doc or they see their urology, and they come and see me for their bowel or bladder. And then they may bring up that they have these sexual issues and that they've never talked to their movement disorder specialist about them. And so some people may even bring up the fact that they didn't even know that was a symptom of Parkinson's or a symptom of medication, if they have the hypersexuality or if they have low libido or et cetera. And so I think some people can really benefit from the education of specialists like myself, who has concentrated much of my entire career on learning about Parkinson's and pelvic health. And so I feel like I can offer that to people, and I try to educate. I've written my own course about this specific topic, that I feel very strongly about the education piece, because some people just don't even know to bring it up. And I think that I'm hoping to get the word out there to just tell people to tell your doctor, tell Dr. Ospina, tell her about it so she can help you. Because if the medical aspect isn't ironed out, as she mentioned, then it's much harder on the therapy side to make change, because we have this medication or something more medical that is impeding us from making that progress. And I think that in therapy, what's really great about OTs and PTs that are specialists in pelvic health is we really get a lot of time. Most clinics give about a 60-minute appointment. And I really can take the time to dig into some of these things and provide the resources. We can try things out. We can have partners come to the session. There are things that we can do and I can teach to help get over some of these barriers.
I love that. And it definitely needs to be a team approach. And I really wish there were more centers out there that actually approach this from the very beginning of diagnosis and try to kind of head off things as before they get there, and have honest conversations from the very beginning, and then validate the care partners and those who are struggling with the emotional aspect of trying to balance care, be a spouse, feeling guilt. Their feelings are valid, they're real. There's no easy answers to a lot of the issues. And I think if we started normalizing these conversations early on and give people an opportunity to really talk about them, not just, address it from the medication treatment perspective and from the therapeutics perspective, but from the psychological perspective, that, this needs to be treated as a whole person. The situation, needs to be addressed from all spheres. And it's very important. And it is challenging, especially in the advanced stages, for the person living with the disease and having all of those changes and trying to, still get their needs met. And then the care partners, which may actually have different needs. Their needs may be, needing somebody to just hear them, knowing that they're exhausted, having time for themselves. That might be what feeds their need. It may have nothing to do with intimacy and sexuality, but then there's still that relationship that often gets very lost in the role of caregiving. And so giving them an opportunity to be validated on that. And I guess the next kind of logical thing to discuss is how you would feel, or how you would address someone who has dementia and is wanting intimacy, or they're married and they still have a very close relationship. Are there any points that you would like to make in regard to that topic?
So I think, always you just want to informed consent, and then you never want to feel like, oh, somebody's groping me. I mean, I think, it's difficult if somebody has been a couple and been married for many, many decades. I've seen this sort of happen where then the children are like, well, I don't think that's appropriate. That's something that the couple would just sort of discuss among themselves. But then, it does come up, well, can that person give informed consent? Just like, we take away their checking account and their keys to drive a car. I think that's something that you would discuss among the couple, and make sure that the couple's always comfortable, that one person doesn't feel like somebody said, oh, I feel like they're always going for the crotch, or I feel like I'm getting groped. So I guess, always my big thing is always communication.
All right. And I would like to know if there's any thoughts that you have for those in our audience that might be single in dating and might be interested in having, an intimate relationship with someone.
So I think, yeah, just because we've sort of had a little bit of space here in the clinic, is that just because you think, oh, I can't get pregnant, that you should not practice safe sex. You can still get an STD. Things like chlamydia are drug resistant, so we want to stay away from them. We had one patient where they, came in with this rash, and the rash turned out to be syphilis. So that we want to make sure that we're always practicing safe sex, even though you think, oh, I'm too old, I'm not going to get pregnant. Always practice safe sex, especially if you're single and you're out there in the dating world. But again, always communicate so that you both feel like, oh, I have a positive self-image. And I think that's one of the problems with Parkinson's disease. They feel, like you said, oh, my skin is different, my smell is different. I have this tremor or have these involuntary movements. It makes me self-conscious. So that you find a partner that you feel comfortable with and that you don't feel self-conscious with. And that you practice safe sex.
Okay, I'm going through here just to make sure that I haven't missed any questions. And anybody in the audience that wants to unmute themselves and ask a question, feel free. We still have a few minutes left. I just going through here to make sure I haven't missed anything. Someone would asking about orthostatic hypertension and being able to take medication. So sometimes Cialis or Viagra may not be safe. So if that's the case, then you would recommend some of the other tools like rings and things like that.
Right. So always you want to make sure that everything's checked out by your physician and that the benefits of the medicine outweigh the side effects of the medicine. That we're not going to give you a medicine that, yeah, you might have an erection, but you can't stand up and you faint every time you stand up. And that leads to falls, that lead to broken bones, to an ER visit. So with everything, we always want to make sure that the benefits of the medicine or the therapy outweigh the side effects of the medicine or the therapy.
And another person said, asked, why do I feel better when I have a strong sex drive?
I think you just feel more alive, and you have less depression, less anxiety. Remember, sex is a way to reduce stress in your life, and it's quite pleasurable. So if we can keep that going, I think overall you are a sexual being, and as Anissa said earlier today, you're a sexual being until you stop breathing. And so that we want to keep you whole as much as possible, even though you have Parkinson's disease. And so that we want to make sure we keep everything whole, and that we haven't tweaked one thing more than the other and put everything off balance, and that we have your libido just where it needs to be, not too high or not too low. Just like we do your motor symptoms. We try to address your motor symptoms so that they're well controlled throughout the day. The same thing we have to do with your non-motor symptoms, like the blood pressure. We have to make sure that it's normal so that it's not too low that you're fainting when you stand up, or too high that we put you at risk for, a stroke or a heart attack. The same thing with your libido, that it's where it should be, not too high that we're getting into trouble, and not too low where, you have a lot of what we call abulia or apathy.
And two, when you have things that happen pleasurable to you, you get endorphins, or like those neurotransmitters that make your body feel better. Some people get that a lot when they exercise, when they run, when they bike, or things like that. And that can happen with sex too. And that does make you feel better because it gives you those pleasurable transmitters that make your body feel good too.
So I think, and also something that happens in Parkinson's very often is that, you've been a couple for so many years, and then all of a sudden now you're the patient and the caregiver. And we want to get you back to being the couple, if possible, and to stay, not always be in that patient caregiver role, so that we can get you back to being the couple that you were 20 years ago. So I think in that sense, there's less caregiver burden if we can keep that balance right, where you're not always the caregiver and you're not always the patient.
And, one thing that I want to point out is that, again, intimacy isn't just intercourse. It can be just holding hands. It could be skin on skin contact, just, getting in bed and spooning, and, it not going anywhere else, and just talking. Or maybe you don't talk. Maybe it's just being together. And what as humans we need is that physical contact. We need that. It's good for us. It releases good chemicals, and if it helps you to connect. And if sex is not something that you're interested in, or you can still hold hands. You can still, caress somebody, and give them loving affirmations. And that can be intimacy. You don't always have to have sex, intercourse. I mean, we referenced a little bit using toys. Masturbation is a healthy and fine thing to do. So if that is what helps you to, feel that release, by all means, there's nothing wrong with it. There's no reason to not even do that together as a couple, so if you're a single, fine. If you're a couple and that is helpful to you, that's a way of connecting. I feel like we just need to expand what we think of as intimacy, and see more of a yes and approach, that you don't have to have it one day. We're dealing with this, and we're going to have intimacy by, just sitting down and cuddling and watching a movie together, or laying in bed and just holding hands, or just being close to one another. Or, if you have to help your loved one in the shower, then get in with them and take a shower together and make it, a situation where you're killing two birds with one stone, so to speak. You're helping them, but you're also making an opportunity to connect. So we only have like one more minute left. I don't know if Dr. Ospina and Erica would like to share some last words with our audience today.
I agree. So I think we have to think outside the box and just make it more expansive, that sex just isn't sexual intercourse or penetration. That, as Anissa said, you can take a bath together, you can have a massage, you can have intimate time together. And again, just communicate with your partner what your needs are, you know, what works for you, and to communicate with your physician as well.
And that there are specialists that can help, and that not to lose hope. If this is something you want to have some help with, there are resources out there, and hopefully I provided you guys with some of the starting points today to seek that out. And then Dr. Ospina and other physicians hopefully have those resources as well to send you off to the right person that knows something about Parkinson's and pelvic health and can help you get through some of these things. We can do something about it.
And I want to encourage everyone to, you know, if they're having issues, to please talk to your doctor about them so that they can get you in the right direction. If it's a medical intervention, if it's a therapeutic intervention, please don't hesitate to ask. They may not know to ask the questions, but if you're struggling with it, like Dr. Ospina said earlier, you know, it may not, the wearing off or the tremor or whatever may not be as big of a deal for you at this visit as this issue. So please feel free to ask those questions. So I want to thank everybody for joining us today. I want to thank Dr. Ospina. I want to thank Erica for joining us for this conversation. It's been a fantastic hour with the two of you. Thank you so much for being a part of it.
Thanks for having us.
And I want everyone to give them the wave of gratitude, because it's been wonderful. I'm so glad you joined us for this conversation. I hope you have a good rest of your Monday. Thank you so much.
Thank you.
Bye-bye.